You can start your session now.
Thanks, Sanjana. Good afternoon, doctors. Welcome you on this webinar on role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. 300 plus products in portfolio and presence in 126 plus countries with 21,000 employees globally, and Hetero Healthcare is amongst the largest manufacturers of ARV, APIs and FDFs in the world. Hetero Healthcare is Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India, wide product range encompassing multiple specialties and pioneering in quality and innovation. Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir and Remdesivir to the patients, because of which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have Dr. Pramod sir as our moderator and Dr. Ketan Shah and Dr. Ravindra Chopra as speakers. Welcome Dr. Zog, welcome Dr. Shah and welcome Dr. Ravindra Chopra. Dr. Pramod sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP and author of book Cophology. Dr. Ketan Shah sir is MDDCH, President Surat Pediatric Association 2003, National Trainer ATM PSPP ASK IIP CPIDC. How do I investigate? National Antibiotic Practice, National TB Module, Rapid Module. National Secretary Pediatric Rheumatology Chapter 2005-6, Organizing Chairperson National Rheumatology Meet 2006, EC Member Gujarat Pediatric Association 2014 and 2019, EC Member ID Chapter 2013. Dr. Ravindra Chopra sir is MBBS MD, Chief Pediatrician and Director, Muskan Children's Hospital, Surat. With this brief introduction, I welcome Dr. Zog, Dr. Ketan Shah and Dr. Ravindra Chopra. And over to you, Dr. Zog, for further deliberation.
Thank you, Dr. Prashant. Thank you. So we are here to discuss about an important disease like influenza and the role of oseltamivir in management of influenza. And we all are aware that the monsoon in many parts of our country is in full swing, and quite a few viral illnesses are troubling the children. And there is a major group of illnesses which we call as influenza-like illnesses. These are the children who come to us with fever, cold, and cough. But the father of all those influenza-like illnesses is influenza. And this influenza does not restrict itself with minor cold or cough, but it is a systemic disease because it produces severe headache, high fever, also produces pain, and the child finds it very difficult to walk. And many times I have seen, parents lifting a child and bringing the child to the OPD. That severe is the weakness. And once upon a time, we used to think that influenza is, minor. We need not worry. It's a viral illness. It is self-limiting. But the days have changed. In fact, there are some viruses which I call as naughty viruses. These are all RNA viruses. And RNA viruses like COVID-19, RSV, and this influenza, they are the ones which are known to change their structure very rapidly. And that is why for COVID-19, we had to change the type of vaccine. Even for influenza, we have to change the vaccine every year. So when we deal with influenza, we have to be very, very careful. And influenza is also known to complicate into different things like acute respiratory infections in the form of pneumonias or acute otitis media. And children, many times, they lose their school days. And many times, influenza doesn't remain very benign. I have seen patients of influenza getting into complications of the central nervous system. And I remember when I was a resident, we were afraid of giving aspirin to these children of influenza because we had a condition called Rye syndrome, wherein, there was liver involvement and liver failure. So for a child coming for influenza-like illness, we usually, give paracetamol to control fever and not aspirin. So there are many things related to this illness. And one of the most important things is that we have to use the antiviral agent oseltamivir early whenever you suspect influenza. So we have to discuss a lot about the disease, about the clinical presentation, about the early use of oseltamivir. We have to see some cases in our practice, and then clarify some of our doubts related to these respiratory illnesses. So I am fortunate to have Dr. Ketan Shah and Dr. Ravindra today for this particular discussion. And in the initial part, both of them will convey a lot of information about influenza and oseltamivir. And in the latter part, we will have some questions and answers related to this particular topic. So I hand over the screen to Dr. Ketan Shah so that he can start with the proceedings.
Thank you, Dr. Jog, sir. It has been great pleasure to be with you, sir. Dr. Ravindra, a very meticulous academic person, and Dr. Prashant and the hetero team for giving us this wonderful opportunity. As Dr. Jog has rightly said, this is the season where we get a lot of cases of viral illness. And there are many healthcare challenges in monsoon. We need to diagnose them properly. We'll be discussing about influenza, like it's called as a flu, and its complication, clinical evidences of oseltamivir for its uses in practice, and guideline recommendation for empiric use of oseltamivir. So the main focus is monsoon season, respiratory illness, influenza-like illness, influenza, role of the drug, and how does the drug works for the better recovery. So stepwise, we'll go ahead with these topics. As we discussed, the monsoon would have influenza-like illness, H1N1, severe acute respiratory illness called as a SARI, and a COVID-19. COVID has not yet gone out of India. Few scattered disease reporting has been still going on. Fortunately, there is no epidemic of a serious COVID-19. India and flu disease. There are a lot of myth that flu does not exist in India, but now it has been proved beyond doubt that flu does exist in India. Which season does it come, and what is correct time to vaccinate? This picture has been taken from Purple Book of Indian Academy of Pediatrics, which we call it as a Gita of vaccine for Indian pediatrician. This graph clearly narrates from 2014 to 2019 the incidence of flu peaks in January to April, and the second peak starts from June and ends into the October. For a couple of days, in last 3-4 days, the number of respiratory illness has reduced, but prior to that, during Ganpati festival, and prior to that also, we had a huge peak of influenza-like illness. Again, this is the statistics of global burden of disease. It clearly narrates that the episodes of respiratory infection or influenza-like illness was significantly high, and the death has been reported almost 26,000 in 2017. These are the Indian data, again taken from Purple Book. 2017, we had 38,000 cases and 2270 death. And in 2022, we had 12,000 cases and 399 death. That was up to 31st November 22. Indian data says that 5 to 10% of all ARI are due to influenza. 10 out of 100 child per year suffer from influenza. Almost 170 to 180 per 1,000 children per year below 1 to 2 years, they do suffer from influenza. And these are the two different studies from North India. Influenza associated ARI 33 to 44 per 1,000 children per year has been reported. And in 2009 pandemic, 22.8% positive cases for influenza in pediatric population has been reported. And in 2015 up to March, 30,000, more than 30,000 cases with 1809 death has been reported. In North India, the peak is between Jan to March, Central India, July to September, and Southern India, September to November. So we predict that winter and monsoon are the peak season, and pattern of circulating strain varies from country to country. This is again a statistical demonstration of overview of flu disease in India. The last line of 2019 does indicate that the death of almost 1 to 1.8 people was reported in 2019. So there are increasing case reports of influenza in India. Dr. Ravi, over to you. This is a very small study. Can you elaborate the study? Over to you, Dr. Ravi.
Yeah, thank you, Dr. Ketan. Thank you for nice statistical analysis of influenza so far. So this is one of the milestone study that people used to think there is no influenza in India and influenza season doesn't exist in India. So this was a breakthrough study. It was done in Department of Virology in 2019 at the King Institute of Preventable Medicine and Research. And over the 7 years, they had collected 36,370 specimens, and they were subjected for influenza analysis for the seasonal pattern and influenza positivity. The staggering positivity was reported on these samples, and positivity started with the onset of the monsoon and it peaks during the post monsoon months. So, as we all day to day see in our practice, that influenza positivity is typically seen during these months.
Thank you, Dr. Ravi. So once again, these study stems that influenza does exist in India, and the peak comes in monsoon and even in the post-monsoon months also. Influenza virus, we all know that it is a very most common infectious disease caused by influenza virus. It is highly contagious, airborne disease, seasonal epidemics occurs, and it can present with mild to severe illness, and serious outcome of flu infection can result in hospitalization or even death. And there are 3 types of influenza virus. Dr. Ravi, can you elaborate? What do we mean by A, B, C, drift and shift? Over to you.
So, influenza virus is a RNA virus, and it is subcategorized amongst the typified on the basis of nucleoprotein and M capsid into influenza A, B, and C according to their variability, and as well influenza D. But for humans, influenza A, B, and C are important. And influenza A is further classified into different categories on the basis of heme agglutinin and neuraminidase into H1N1, for example, H1 to 18 and N1 to 11. Different subtype in different permutation and combinations do exist. So influenza A is most important and most frequent virus. It causes frequent epidemics because of antigenic variation, which we'll talk. And there are periodic pandemics also in this virus, and this virus has been most important viruses. Influenza B is the second important virus. It infects only humans and causes local epidemics, very less likely to cause pandemics. Influenza C is a minor proportion of the virus. It infects human and swine. And this virus, in fact, generally causes a mild respiratory illness, which may sometimes go unnoticed and does not cause any epidemics. So there are drifts and shift, which are mainly meant for influenza A virus. So drift is a kind of a reassortment in the genome of the virus. So minor antigenic variation which leads to seasonal variability of the influenza. We might have heard about northern strain and southern strain. This is because of the variability or minor drift in the virus, which escapes our immune system to an extent. And shift is a total reassortment of the virus. So this is kind of a new virus, and it is antigenic epitopes change completely, and it completely fools our immune system. And this virus causes huge epidemics and pandemics, like we had our swine flu epidemic last, and similar epidemics in the past also. So we have to keep this thing in mind while studying influenza, that these kind of viruses are there, and there are drift and shift which leads to a new virus and new kind of a antigenic challenge to our immune system, and hence almost every time we have a newer vaccine. Over to you, Dr. Chetan.
Thank you, Dr. Ravi. So it was a very nice presentation mentioning about ABC virus, drift and shift. As we know that the flu virus spreads from one person to another person, it can spread up to 6 feet away. It can spread by droplet. Even when you sneeze, when you cough, when you shake the hand, you are likely to get the disease. And children may pass the virus for longer than 7 days. Even before the symptoms begin, you are contagious and the disease can spread. So it is better to have a school leave for children, maybe up to 7 to 10 days, whenever they get the influenza-like illness. There are symptomatic differentiation of influenza-like illness, H1N1, SARI, and COVID-19. Dr. Ravi, can you briefly differentiate this type of symptomatology? Over to you, Dr. Ravi.
It's easier said than done. Clinical differentiation between these diseases will be very difficult and nearly impossible. So ILI being a prototype, so it causes almost includes everything. It has fever, myalgia, cough, lack of energy, sore throat. But the severer form like H1N1, sorry, they have a more of respiratory compromise, breathlessness, including COVID also. But the typicality of COVID is generally presentation with fever, breathlessness, and loss of smell and taste, which is quite peculiar to COVID and often not seen with other viruses, though it may be present in some other illnesses also. And as far as the other systemic signs like myalgia, body ache, they can be there in H1N1 and COVID, more profound in influenza. And the systemic signs like diarrhea are more common in COVID. So this is how we try to differentiate these illnesses. But clinically, it is quite difficult, and we have to resort to investigation for proper diagnosis and treatment of the child.
Thank you, Dr. Ravi. Just to share that today morning at around 1 o'clock, I have admitted one adolescent child who came to me with a history of fever, cough, cold, severe prostration. कि सर बहुत थकान लग रही है, चल भी नहीं रह सकती हूँ, बहुत वीकनेस है, चक्कर आते हैं, और there is no smell or there is lack of taste in my mouth. मुझे कुछ भी खाना अच्छा नहीं लग रहा है, टेस्ट नहीं आ रहा. Her CBC was normal. X-ray was showing bronchovascular markings prominent. So this could be COVID, or sometimes even H1N1 can present in this way. We have admitted the child, and if the parents permit, we'll go for the investigations also. There are always some warning signs of flu sickness, as the adolescent child who comes with little bit breathlessness, weakness, not able to stand. As taught in the PALS program, we always look at the ABC, airway, breathing, circulation. Any child who is breathing fast, getting hypoxia, that means there is an impending respiratory failure. If there is a cyanosis, if child is irritable, these are all, it need to be taken care. Excessive crying, or even a dull child who is not responding properly, who is not able to sit, who is not able to walk, who is getting breathlessness, and in the adult, if you get a dizziness, confusion, persistent vomiting, these all are worrisome symptoms of flu-like illness. Always when you suspect the disease, some parents really want a confirmed diagnosis. So, Dr. Ravi, can you highlight what are the diagnostic tests of influenza-like illness?
So
Over to you.
commonly used diagnostic test is the gold standard, which we do day to day is in our practice is PCR test. So it can be typified PCR or a standardized PCR, that is in the form of multiplex PCR, or we can do a non-typified PCR like a flu panel test, which will tell about the influenza A or B. And the gold standard though remains viral culture, which is only for theoretical or research purpose. Then there can be use of rapid antigen tests for influenza, which are not reliable and no standardized kit is available. And very rarely there is a rise in antibody titer, which can be taken as a marker of infection. So, but in general practice, along with the clinical diagnosis, we have most important test is a PCR. And if I talk about complications of flu in children, like we see day to day, one of the commonest thing I see in kids is otitis media, which is very common in our practice, even during flu or post flu also we see. Then there are chances of flu pneumonia and secondary pneumonia, bronchitis. Then ALTB sometimes can be seen. Then other systemic involvement like myocarditis and rhabdomyolysis, muscle involvement is also seen with flu. And one of the rare complications is Ray's syndrome in children if accidentally ingested or accidentally given aspirin along with influenza infection for fever purpose. In adult, the complication can generally are in the form of exacerbation of the underlying illness like diabetes, COPD, renal failure, and all these things, along with lower respiratory involvement in the form of severe pneumonia and ARDS. So these are the common complications in children and adults.
Thank you, Dr. Ravi. We all know that any respiratory disease comes, all existing disease on respiratory tract gets worsened, and from the nose to the alveolar level, you will have a damage, and the secondary complications with cardiac, renal, and CNS can come up with flu also. So we'll just go to the management of influenza. There is an antiviral therapy, Oseltamivir, which has been proved drug. We'll discuss about these drug in subsequent slides. The basic modality of treatment is bed rest, increased fluid consumption, cough suppressant, antipyretics, and analgesic like paracetamol, occasionally NSAID, and most patients with influenza, they recover in 3 days. However, malaise may persist for weeks. Patient will tell कि सर बहुत थकान अभी भी लग रही है, कुछ टॉनिक लिख दो, कुछ विटामिन्स लिख दो. And then we need to explain them that post flu you will have a malaise for a couple of weeks, and severe cases may require intravenous hydration and other supportive measures. The flu-like illness has been divided into category A, B, and C. Category A is a very mild disease where you have a cough, cold, low-grade fever, walking, happy child. Category B is a little bit more serious presentation, suddenly a high-grade fever, severe body ache, severe coughing, running nose, and prostration. Category C, further complicating the things, high-grade fever, difficulty in walking, breathlessness, other system involvement. You have a lot of coughing, hypoxia. So this is category C. A, B, and C are just a clinical differentiation of influenza-like illness. However, they may overlap, or today patient might be in A category, may deteriorate to become B, and may deteriorate to become category C candidate. We have antiviral drugs. One is a neuraminidase inhibitor, and another is adamantinase. Neuraminidase inhibitors, they block the viral neuraminidase enzyme, which is critical in releasing viron from the infected host cells. These drugs are active against A and B type of influenza, and the prototype drug is oseltamivir. Zenamivir, not very well studied and not easily available also. Adamantinase, they interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. It is active only against influenza A virus. The example is amanitin and remanitidine. So out of these two categories, neuraminidase inhibitor oseltamivir is a preferred drug. Oseltamivir is a potent and selective inhibitor of the enzyme of influenza A and B. It is a prodrug converted to oseltamivir carboxylate in the liver. It inhibits influenza virus replication and its pathogenicity is reduced. It prevents further spread of infection and it is effective against A and B variety both, which includes the avian and swine origin of H1N1 and H9N2 strains. This is a pictorial presentation of oseltamivir. From the viron, there is a neuraminidase enzyme. There is a release of new viron and the virus multiplication continues. If you have a neuraminidase inhibitor, it will block the formation of new virus. Thus how the viremia reduces significantly if neuraminidase inhibitor is used. So it was the first oral neuraminidase inhibitor which has been approved in more than 100 countries by FDA, CDC, and American Academy of Pediatrics, and even the Indian Health Department. So the dosage would be, as we all know, that it is available in 12 milligram per ml syrup or a capsule as a 75 milligram. In the adult, the dose is 75 milligram capsule twice daily for the treatment. The another is a prophylaxis. Prophylaxis is 75 milligram capsule once a day. If child is below 15 kg, dose would be 2.5 ml BD. That comes to 30 milligram per dose or 60 milligram per day. Prophylaxis is 30 milligram once a day. 15 to 23 kg, it's a 90 milligram per day. It comes to 3.75 ml. 23 to 40, it's a 120 milligram per day. The dose comes to 5 ml 2 times in a day. And more than 40 kg, it is 150 milligram per day, either 75 milligram twice a day or 6.25 ml 2 times a day. It can be given to infant 2 weeks to less than 1 year of age. The dose would be 3 milligram per kg twice daily. And prophylaxis in below 1 year is not applicable. This table sometimes is difficult to remember. We can keep it on the table for memorizing the dosage. Now we'll go for the real case scenario. Dr. Ravi, over to you. Please narrate the cases.
So these are my day-to-day cases, and I'm sure we all are getting these kind of cases. And these are included just for our understanding of the clinical symptomatology and treatment options for our kids. So this first case was Isani, 6.5-year female child, resident of Yesu, Surat. The child was immunized for routine childhood vaccination other than influenza vaccine, and child presented with fever high grade 103 to 104 degree Fahrenheit with cough and cold for 2 days, throat pain for 1 day, and breathlessness for few hours before admission. There was no significant past or family history, but there were few friends who were sick in the school. The child was a well-nourished, febrile child, 104 degree Fahrenheit, with mild tachypnea, with a respiratory rate of 42 per minute, mild retractions, tachycardia with normal blood pressure, and SpO2 of 93 to 94% on room air. The throat was quite congested with nasal discharge, which was watery in nature, and chest has bilateral fine crepitations, and rest of the systemic examination was normal. So child was investigated. Her CBC was normal, CRP was also normal. X-ray had shown bilateral perihilar opacities and prominent bronchovascular markings. Considering above finding in a sick child with respiratory distress, we ordered a respiratory multiplex PCR with the consent, and this test was positive for H1N1 influenza A. On the course to hospital admission, child was started on supportive treatment with IV fluid, oxygen with nasal cannula, and oral oseltamivir was added later. The child continued to have high-grade fever for the next 24 hours, 103, 104, and required almost repeated paracetamol infusion over the next 24 hours. After 24 hours, the fever spike started declining, respiratory distress settled down, and child gradually weaned off from oxygen in the next 24 hours. At 72 hours, child was afebrile with no respiratory distress, though the cough persisted. Child was discharged on oral oseltamivir and decongestant and SOS cough suppressant as per the need. So this case highlights that a rapid progression of the disease and a very rapid recovery after the proper diagnosis and prompt antiviral therapy. So highlighting the prompt antiviral therapy. So this is case 2. This is a Presid 10-year, 4-month male child known case of seizure disorder on oral valparin. The child did not have any seizure for the last 1 year and was planning to taper valparin. The child presented with persistent cough for 3 days, fever third day, uh, around ranging from 102 to 103 degree Fahrenheit, with weakness, body ache, and heaviness of the chest. And there was one episode of stiffness of both the upper limbs and uprolling of eyeballs, which was very transient. So child was admitted in emergency. The child had a weight of 33 kg, height 137 centimeter, temperature 101 at the time of admission with tachycardia and mild tachypnea, SpO2 of 98% on room air and blood pressure of normal magnitude with no respiratory distress as such. Child was fully conscious and oriented and no abnormal movements were noticed after admission. Throat was grossly congested and chest had shown bilateral conducted sounds and bronchi. CNS and other systemic examinations were normal. So we started investigating the child and hemogram was normal with slight leukopenia. CRP was borderline and chest X-ray had shown bilateral prominent hilar shadows. So we sent a flu panel which was positive for influenza B virus. This was a kind of a X-ray child head with prominent bronchovascular marking and rest of the parenchyma looks almost normal. So child was started on IV fluid, IV amoxicillin, amoxiclavulinic acid and levosalbutamol nebulization. Oral fluvir was added later after the reports. Child showed significant improvement after 24 hours, though the nausea, lethargy, and cough persisted for a few days. There were no further seizures after the admission, and child was discharged on third day on oral oseltamivir with supportive treatment, and valparin was continued. So this child depicts that influenza can complicate the underlying disease and precipitate it. So, for example, in this child, seizures were precipitated because of this kind of illness. So, third case is of Avadi, 14-year-old female child. Child presented with fever 6 days. Initial 2 days it was high fever and then decreased in intensity. Child has been traveling to Rajasthan, so taking only oral paracetamol. There was increasing cough and severe lethargy. At the time of admission, child was even unable to stand with lot of dizziness. There was family history of fever and cough in the two of the family members there at Rajasthan. Child was dull looking, febrile 101, dehydrated, BP was on lower side 90 by 60, respiratory rate 30 per minute, 32 per minute, with normal saturation and mild tachycardia with no respiratory distress. Throat was congested, so was conjunctiva, bilateral, and there was evidence of stomatitis as well. Chest had shown bilateral fine crepitation on bases. Rest of the systemic examination was not remarkable. On investigation, child had a hemoglobin of 14.2 and with little leukopenia with TSG of 3,400 and platelet 1,69,000. CRP was normal and bilateral lower zone haziness was noticed in the X-ray. We had done a biofire multiplex PCR, which was suggestive of influenza A H1N1. So this child was started on IV fluid, IV ceftriaxone on admission with nebulization, and later added an oral oseltamivir. So after rehydration, child shown significant improvement in general condition, and the dizziness and lethargy went away. After 36 hours of oral oseltamivir, child improved dramatically with improvement in the fever and respiratory sign, but mild cough persisted. The child was discharged after 3 days on oral medication, only on oral oseltamivir. So this case depicts the effectiveness of oseltamivir even the later phases of the disease. Like in this child, we had started on 6th, 7th day of the illness, and still we had a very significant response to the antiviral drug even within 24 hours. Over
Thank
to you,
you,
Dr.
Dr.
Ketan.
Thank you, Dr. Ravi. Very nicely elaborated the real diagnosed cases of influenza, early onset, early treatment, early recovery, middle or late presentation, and if you start the treatment, even that in these cases, you get good recovery. So same way, these are the high risk category, infant 2 weeks, history of fever, cough, cold, and all family members have a respiratory symptomatology. One adult has been admitted for respiratory infection. He is on oxygen. Clinically, this fits into influenza-like illness, and here the empirical use of oseltamivir is definitely justified. If you don't have a family history of respiratory infection, this could be RSV infection, and we all have seen the epidemic of RSV in last 2 or 3 months. Severe bronchiolitis, hyperpyrexia, prolonged illness in RSV. But usually RSV is a pediatric disease. It does not affect the adult. In this case scenario, adults are admitted, has a serious respiratory illness, so empirical use of fluvir is justified in this infant. Same way, known case of nephrotic syndrome, who is on steroid, already immunocompromised, not vaccinated for influenza and for other disease also. Here also, even a category A of presentation, we need to start the oseltamivir in this nephrotic patient. 9 years old child, known case of asthma, presenting with category A symptomatology like fever, cough, running nose, not very sick. But here, even the empirical use of oseltamivir is justified because flu itself worsens the asthma, and in asthma patient, flu is a more serious disease. So here also the empirical use of oseltamivir is justified. So it has been said that oseltamivir is a wonderful drug for walking pneumonia and early onset severe symptoms. There are benefits of empirical and early use of oseltamivir. There are various clinical trials also. When you start oseltamivir treatment of influenza-like illness, it reduces the prolonged hospitalization, it reduces the use of antibiotic, even it reduces the serious complications. So in patient with influenza, oseltamivir treatment is really justified. Reducing occurrence and severity of pneumonia due to H1N1 by early oseltamivir administration. This study was conducted on 442 patients. The median time from symptom onset to oseltamivir administration was 5 days, and the subjects were divided into 4 groups, less than 2, 3 to 7, 8 to 14 days, and more than 14 days of starting oseltamivir. It has been found that once the empirical oseltamivir has been started, the probability of severe pneumonia gradually and significantly reduces if you start early. If you start even late, the probability of severe pneumonia or worsening of pneumonia reduces significantly. So Early treatment, better benefit, but even in the midway or in the late stage, if you start Oseltamivir, there is no harm because it's a very safe drug. The patients with a shorter time to Oseltamivir administration were discharged earlier from the hospital. This has been shown in this graphic presentation of the study. The recommended duration for post-exposure prophylaxis is 10 days, and for the community outbreak, it can be up to 6 weeks, and in immunocompromised child, it can be up to 12 weeks. So prophylaxis is also recommended in suspected epidemics or a very close contact who is immunocompromised patient. There are guideline recommendations. Even the WHO recommend that empirical treatment is strongly recommended. It should be started as soon as possible. Laboratory confirmation is not mandatory to start the treatment. Negative laboratory report does not rule out H1N1 or influenza disease. And in high-risk individual who are exposed to a patient with influenza, consider presumptive treatment with Oseltamivir. Even the Ministry of Health and Family Welfare, Government of India, has clearly stated that any patient having SARI symptoms or in epidemiological situation, empirical use of Oseltamivir is recommended. So, in adults with community-acquired pneumonia who test positive for influenza, should the treatment regime include antiviral therapy? Yes, there are recommendations. Any patient coming to you with a lower pneumonia, and if you have a positive influenza disease, then empirical use of, not empirical, even in a proved case, if you start Oseltamivir with antibiotic, the outcome is really good with a shorter duration of stay and a less complication. So in summary, proper diagnosis and early treatment can prevent flu complications. Empirical use of Oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. And it has been recommended by WHO, American Thoracic Society, and Ministry of Health and Family Welfare, Indian government, for empirical use of Oseltamivir. Thank you. Thanks to Dr. Jog sir, Dr. Ravi, Dr. Prashant, and Team Hetero for giving us this wonderful opportunity. Over to you, Dr. Jog sir.
Yeah, thank you very much for this excellent discussion. And I was just thinking that Ketan is K and Ravindra is R. So, it's a combination of knowledgeable and rational pediatricians. Okay. So, taking the thread of this rationality, I have a question, Dr. Ketan. Many times in practice, our colleagues face, a child who has cough, cold, and fever. But they are in two minds whether this child has a bacterial infection or whether it is viral. Some or the other, they manage the case because 90% of the cases are viral, and even without antibiotics, children recover. That all of us know. But there are some situations, confusing situations, where our colleagues are likely to be in two minds, whether to start Oseltamivir, whether to start antibiotic, whether to start both, or whether to wait for some time and start either of these. So, how would you guide our pediatric colleagues in this situation?
Thank you, Dr. Jog sir. If I am confused, I am going to call the past national president, Dr. Jog sir. Sir, as a patient आया है, मैं क्या करूं? And I'm sure Dr. Jog sir would be more rational than me. But clinically, if you have a viral respiratory symptomatology, running nose, running eyes, cold, cough, and family history of respiratory infection, it is most likely a viral disease. Then you look at the epidemiology. If the patient is coming into February month or in the September month, probably it's a flu disease, as we had seen the epidemiology. Then you look at the patient profile. If he is not immunocompromised, if he is 4, 5, 6 years old and has a category A symptoms, then probably symptomatic treatment is justified. But if the host factor like early infancy, immunocompromised, or any adult admitted with respiratory distress in hospital, probably empirical use of Oseltamivir is justified in these cases. So clinical symptoms of viral respiratory, host, host factor, and the epidemiology would decide the use of oseltamivir. Thank you, sir. Over to you.
Thank you, thank you, thank you. Now, Dr. Ravi, many times it so happens that, a child is unwell with influenza in the family. And, in the family, there is a, person like the grandfather who is, asthmatic, father who is diabetic, or, mother who is again pregnant. And, there are, situations where there are some high risk individuals in the family itself, and this child has been diagnosed as a case of influenza. Is there something that you need to do related to these household contacts who are in the high risk category like these? Yeah, your mic is on mute, Ravi. Your mic is on mute.
Thank you, sir.
Yeah.
So there are a couple of things which we should keep in mind actually. First of all, the vulnerability of the population, for example, elderly with chronic diseases. So they are likely to get a very severe flu. And hence, the prophylaxis, as Dr. Ketan had already mentioned in his presentation, should be advised to them. 10 days therapy of oseltamivir once a day should be a good enough therapy for those. And maybe in a very young children also who are coming into contact with this case, simultaneously cough hygiene, hand washing, and isolation of the child. So quarantine, which we followed during our COVID time, stay in this case also. So quarantine and isolation of the child along with prophylactic treatment to the susceptible population. And I would advise that all these vulnerable persons should take vaccination. So we should advise them in advance also. And during this episode, it is a good time to counsel them regarding immunization, adult immunization.
That's very good. So I always feel that, children are the ones who transmit influenza to the adults. And during COVID times, we used to, give priority to the adults because we knew that adults are the ones who transmitted it to the children. But here, if there is a child suffering from influenza, it is prudent and important that you take care of the adults, elderly in the family who are at high risk by giving them chemoprophylaxis so that it will, prevent further problems. It is very important. And Dr. Ketan, a last question to you about these tests which we do for the diagnosis of these viruses. So many tests have come of late which can detect either the upper respiratory tract viruses or the lower respiratory tract organisms. And we have tests which detect viruses and bacteria and so on and so forth. So, how reliable are these tests in your opinion? And when should our colleagues go for these tests, and what are the limitations of these tests?
Sir, the tests are recommended on clinical background only. If you have a category A patient who is walk-in patient, testing is not required. Category B patient who has a mild symptomatology, which is treated on OPD basis, testings are not required. Category C, who is in severe respiratory distress, maybe impending respiratory failure, there sometimes we go for the test. And when you get the test positive with some virus like Boca virus, rhinovirus, we know they are not going to create category C patient. Category C patient would be either influenza or could be bacterial pneumonia or could be mycoplasmal pneumonia. So certain virus which are commensal in the oral cavity, which are less likely to be pathogenic, rhino, Boca, Nova virus, they are not important. So these reports should be discarded. But if you get flu positive in category C patient who is on oxygen, that is to be correlated. Same way, if you have a non-resolving pneumonia, and if you are taking a BAL, bronchoalveolar lavage, and if you get something positive from BAL, then it should be given due weightage. Over to you, sir.
It is, yeah, yeah. that is an important point, because these days, many times we are confused whether we should, go for these tests or whether we should treat. But as you have already clarified that even WHO has recommended that you need not wait for the result of this test. If epidemiology is in favor, if the clinical picture is in favor, and if the child is in either category B or C, then one can always take the decision, to start oseltamivir, and also whether to go for these tests. So I am glad that we have discussed almost all the points in relation to flu and oseltamivir, and Ravi has also clarified, certain etiquettes related to the cough, and also this Hasta Pancha Sutri, the 5 sutras related to the hand, like hand washing, avoiding the handshake, using the handkerchief, keeping others at a hand's distance when you are unwell, and avoiding hand touching. Basically, it seems that this particular virus is really a fast and a furious virus with an abrupt onset and high transmissibility, rapid progression even to ARDS, and that is why we also have to be very fast in starting oseltamivir. And it's also important that we vaccinate everyone in the family. Flu vaccination is a family vaccination, and as pediatricians we do recommend this vaccine. But I'm sure even the pediatricians who are listening to this program and who are particularly above 50 must make it a point and take this flu vaccine annually, because we are exposed to children with influenza day in and day out. And that's why we must wear the mask in the clinics, and we also should wash the hands after touching every child, particularly with respiratory infection, and get ourselves vaccinated with the flu vaccine. So with that, I say namaste. And it's very important that even in our day-to-day life, we see namaste and say namaste to all those whom we meet, and not, give a handshake, so that at least from our side, we are clear that we are not transmitting any virus from ourselves to the others. Thank you.
Thank you, sir. Thank you very much. I'm sure your comparisons and this. I mean, this topic you make always interesting. So thanks, Dr. Ketan Shah, and thanks, Dr. Ravindra Chopra, for your live cases, which I'm sure the audience has benefited out of our interaction. Thanks all the doctors who took time and attended these sessions. Thank you, Samriddhi. Thank you, Sanjana. We can sign off, sir. Wish you a very pleasant evening and see you soon. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you.